2, 1.
Good afternoon, everyone. This is Casey, the current president for MACVPR. Thanks for joining us this afternoon. Today, we're really excited about this topic. We wanted to get this one going quick now that we're kind of seeing this coming through our doors these days, but this talk is related to COVID and its impact on lung function and how pulmonary rehab could be an option for post-COVID patients. And really thrilled with the speaker we found for this topic, and we're excited to have her here. But just a few housekeeping items before we get going here. This is being recorded, and you can find this on the MACVPR website. So if you do need to come back and reference this talk at any point, please do so by hitting our website, and it should be right there on the homepage is where we've been posting these previous talks. And just so you guys know, we're kind of in the process of trying to figure out continuing ed for this. This topic came up so quick, we wanted to get it out that we didn't really get a chance to go through the entire process of continuing ed, but we are looking at trying to see if we can get this done in the back end. So if we do get that done, you will see an email regarding that. And then just so you guys know, if you have questions today, just please use the Q&A field, not the chat feature. If you do want to use the chat feature for other conversations, please do so. But as far as questions, please put those in the Q&A field so that way we can reference those at the end of this conversation here to make Zinder has a chance to help answer some questions regarding that. So I guess without any more housekeeping items, Dr. Karen Gregory is an acute care advanced practice nurse with a specialty in asthma, allergy, and pulmonary medicine. She's a registered respiratory therapist and has been a certified asthma educator since 2002. Dr. Gregory is an advanced practice provider at the Oklahoma Allergy and Asthma in Oklahoma City, Oklahoma, as an associate professor at Georgetown University School of Nursing and Health Studies. Dr. Gregory serves as co-chair for the American Academy of Allergy, Asthma, and Immunology, Allied Health. She serves on the COVID-19 task force for the American Academy of Allergy, Asthma, and Immunology Allied Health and Associate of Asthma Educators. She's also past president of the Association of Asthma Educators. Dr. Gregory worked as a pulmonary rehab coordinator for 10 years early on in her career. So it's nice to see she strikes a chord with people in attendance today. So with that being said, Dr. Gregory, I'll hand it to you.
Oh, thank you, Casey, so much. And I want to thank each and every one of you for allowing me this opportunity to talk. So today we're going to be talking about post-acute sequelae of SARS-CoV-2, PASC. You might hear this term as long haulers or other terms, but we're going to really talk about caring for our patients with pulmonary disease with a big focus on pulmonary rehab. And again, I want to thank you. My disclosures, there's no conflict today, but I speak for Genentech and Pfizer, but there's no conflict at all. So again, thank you so much for inviting me to talk to you today. Pulmonary rehab plays a vital and critical role in managing patients with lung disease, but especially now we're seeing with COVID-19. And as I was preparing and reviewing and studying for this talk, I was so excited to get to do, I learned so much about pulmonary rehab is a big need for our patients with lung disease who have COVID. And it is near and dear to my heart. Like Casey said, I was a pulmonary rehab coordinator in Oklahoma City for about 10 years. And during that experience, I saw firsthand the great outcomes of pulmonary rehab. And I still am involved with the American Association of Respiratory Care. And we had the AACVPR keep it on, just kind of keep my hand, just kind of peeping and seeing what's going on. But we trust our patients, and our patients trust us. And we build a strong bond with our pulmonary rehab patients, and we cheer them on in the hard times and in the great times. So I commend you. It's vital that we keep current in the literature and keep current on this ever-changing COVID-19 that has impacted the whole world. And we'll really be talking today on the impact of lung functions and how pulmonary rehab is an appropriate option for post-COVID patients. So I'd like to discuss with you the pathogenesis briefly of COVID-19. I would like to analyze the impact of COVID-19 on the lung functions, and then describe post-acute SARS-CoV-2 or long-haul COPD, what some patients with COPD may call long-haul or there's multiple terms for it, but we'll call it post-acute SARS-CoV-2. And then its prevalence, and then how pulmonary rehab can improve health and quality of life in our patients. I do see some COPD patients. I have a COPD clinic too, and we refer to pulmonary rehab. So the severe acute respiratory syndrome, coronavirus 2, as we know, is a novel coronavirus that is responsible for this amazing, like we've never seen before, outbreak of a series of acute atypical respiratory infections. And again, it as we know, originated in Wuhan city in China. And COVID-19 displays symptoms ranging from mild to severe, and it can even lead to death, as we know, in many individuals. And it can, the system this disease can spin on a dime, is what I hear people say, because it can go from mild to severe at the snap of a finger. And major manifestations of COVID-19 is the respiratory tract, and the general extent of organ involvement and the microscopic changes in lung functions remain insufficiently characterized. However, the good news, COVID-19 cases and deaths in the United States have dropped to the lowest level in nearly a year, and the number of patients vaccinated continues to grow. Early in the pandemic, we saw 1 in 5 patients with COVID requiring hospital admission. About 5% of those required intensive care. So our healthcare system, we all have been tirelessly and creatively just in a ramping up capacity of these acute ill patients and what to do now. There is less attention that's been given to post-hospital patients, but I can see the need, I can see it's up and coming after preparing for this presentation. So take home point, there has never in the history of mankind been a disease that has presented in so many different ways. I love this, and I know you've all been following this, but if we look back, this is March 22nd of last year. In the US, we saw 32,000 cases, 400 deaths, and we were all devastated. About 3 weeks later, it increased to 1 million. The second is April 13th. And the deaths increased from 400 just 3 weeks ago to 118,000, or over 118,000. This morning, I just took this about, it's 10:24 Mountain Time, but we have, look at the case now, 33 million, over 33 million cases, almost 600,000 deaths. And I was so proud of our President Biden, how he honored how he's been honoring the deaths. And but look at the vaccination dosage administered. This is incredible, and this is what we need. So let's look at the pathogenesis of COVID. So the coronavirus is a multi-stranded RNA virus that was previously seen in 2003. So this isn't a new thing. Some of our patients may say this related to the vaccine. Oh, we just learned about this a year ago, but that's not true, because we've seen this in 2003 as SARS-CoV, not SARS-CoV-2. And then in 2012, the MERS-CoV-2, the Middle Eastern Respiratory Syndrome, early infections of SARS-CoV-2 has targeted the nasal and bronchial epithelial cells, and through the spike, as you can see, I don't know if you can see my pointer, but you can see these spikes where it gets its name. These spikes is where coronavirus, it means crown, and where it gets its name. So the SARS-CoV virus consists of 4 main structural glycoproteins: the spike glycoprotein, the membrane protein M, the envelope protein, and then the nucleocapsid protein. And all of these, once inside the body, the virus binds to the host cell, which you heard as the ACE, and as the ACE2 receptor. And actually, the SARS-CoV, the first SARS-CoV binded to the same thing, but now it's been reported that SARS-CoV-2 has a higher affinity for the ACE receptor. But inside the host cell, the virus undergoes replication and formation of that negative strand RNA by pre-existing single strand positive RNA through a polymerase activity transcription. So you can see here the SARS-CoV-2 virus with the spike protein, how it enters the ACE2, it enters the body, lands on the ACE2 receptor, and then we start seeing other complications. We see it can go to the lungs, it can go to the liver. You've heard of the cytokine storm with all the interleukin release, and then type 2 and going to the lung. But our interest is in the pulmonary system. But the binding of that SARS-CoV-2 to the ACE receptors could arise in the acute systemic inflammatory response, causing the cytokine storm. And then consequently, that leads to like lung resistant or dendritic cells activation. And but we're still learning the sequelae of this infection. Each day, new studies are coming out. The classification, the COVID-19, asymptomatic, mild, moderate, and what we would probably see moderate with the oxygen saturation greater or equal to 94%. Severe, this oxygen saturation begins to lower. Then we start seeing increased respiratory rate over 30 and lung infiltrates greater than 50%. And then critically, so this would be where we would, our patients moderate, severe, or critical. We may see some mild. And one thing I want you to know is that the post-acute COVID syndrome symptoms can be mild, they can be moderate, or they can be severe. Just because they have mild symptoms doesn't mean they can't go on and have have this late post-acute problems. And then critical is individuals who have respiratory failure, septic shock, or multiple organ. I wanted to just show you how the CDC has been, in my opinion, so amazing. This is an updated list of underlying medical conditions that puts adults of any age at high risk. So I know most of our pulmonary rehab patients are older, although we can have some younger, but it puts them at higher risk for severe illness from the virus that causes COVID. And it's based on research and published reports. So we can see there's nothing no conditions were removed from this publication by the CDC May 13th, but we could see smoking was based on evidence published between the last year. But the new thing that was added is pregnancy-related references were added. So cardiovascular disease, hypertension, diabetes, COPD, and other lung diseases. What we see, we may or may see cystic fibrosis and pulmonary rehab. These are all still risk of severe illness. I'd like to touch too on racial and ethnic health disparities. These are risk markers for underlying conditions that affect our health. Including like socioeconomic status. So that's real important as our patients in our pulmonary rehab programs that we don't ignore this. We want to look at access to health. Are they not coming to pulmonary rehab because there's no access to health? Exposure to the virus related to occupation. Perhaps they're a frontline worker. Perhaps they're, a critical infrastructure worker in the hospital and or essential worker. And some people from racial and ethnic minority groups may hesitate to seek care because they may distrust the healthcare system. So again, I think that's where we do such a great job in pulmonary rehab is establishing that trust. And it's not a one-time visit and they're gone. It's weeks after weeks after weeks, and I think that has improved trust. Persons from racial ethnicity or minority groups are disproportionately affected by COVID. They experience increased risk for infection. They have increased hospital admission and deaths. And the high percentage of COVID-19 are among non-Hispanic white people. And however, racial and ethnic minority groups are disproportionately represented among COVID cases. So the percent of cases for racial and ethnic minority groups are higher than the percentage of these populations that's within the United States. Clinical, so let's look at the clinical manifestations. The most common are fever, cough, dyspnea, can't breathe or can't taste, can't smell. We hear that. Sometimes that goes away. Most of the time it goes away, but it can linger on. We see that in the post-acute phase. And COVID-19 infection can be asymptomatic in a significant number of cases, and they can go on and develop post-acute complications. Most people with COVID experience mild or moderate symptoms. Approximately 10 to 15% progress to severe disease, and then again 5% become ill. The incubation period is now, I think, 2 to 10 days. It might, some of the literature continues on that 2 to 14 days, where we had to quarantine. I hope you haven't had to do that, but quarantine for 10 to 14 days. But there's no uniform definition of what constitutes symptomatic COVID, according to the World Health Organization and the CDC, because it is so unpredictable. I love this diagram here. It is from last year, March 12th of 2020, but I still love it. I think it really shows the CDC's work, but it's really easy for patients to read. Again, clinical manifestations of SARS-CoV-2 can vary. I just want to show you here, they can range from asymptomatic to, to atypical pneumonia, hyperinflammatory phenotype, respiratory failure, ARDS, we see that, and then high prevalence of venous thrombolytic disease and pulmonary embolus. So very, very important. A small portion of patients may have severe disease and require additional ventilatory support. And but then again, we're going to be talking about this, but pulmonary rehab needs to be, just because they're in the ICU doesn't mean we don't need to start pulmonary rehab at then. The most severely affected COVID-19 population are older men, Black, Asian, and minority ethnicity, and then comorbidities such as obesity, hypertension, or diabetes. Autopsies have shown, I was really some great information on the pathology of COVID related lung damage. The autopsy suggests that there's a focal damage of microvascular pulmonary circulation, and that could be, that is generally lethal. And it may also be caused by persistent lung damage in patients who recover from severe, but then, have ongoing lifelong, possibly, we don't know, because we haven't been dealing with this, but since a little over a year. It's essential to detect alterations in pulmonary functions for diagnosis and follow-up. I think that's where pulmonary rehab can play a vital role here, because we're seeing them so frequently, and we can look at signs and symptoms and then maybe refer to the pulmonary function lab, or if it's done in your in your facility, however it's done in your facility. Post-infection patients showed impaired lung function. Most of the literature clearly supports that post-infection COVID patients show impaired lung functions. And most important of the pulmonary function test was the diffusion capacity. If we look at the characteristics of lung damage caused by COVID, again, just looking at the pathological studies, and this is a study just published in January of this year, and it also saw diffuse alveolar injury, fibrogenous protein extudation, at the alveolar level, some problems there, and transparent membrane formation. So really key in and how devastating this can be. We looked at CT findings. That's kind of disputed. It may see ground glass appearance and these crazy, that's the true name, crazy paving patterns. They are crazy, but that is the true name. And that is like a linear pattern superimposed on the background of that ground glass opacity. And I think it's very important that that the healthcare team knows this, because really helping in management. But it resembles on CT this paving stones. That's where it gets its name. But the key finding in COVID-19 pneumonia, which we're seeing, is the ground glass opacity. The GOLD guidelines say it is unclear whether patients with COPD are at increased risk of becoming infected with SARS-CoV-2. I saw this earlier. I'm watching carefully and closely for any changes or updates. But patients with COPD have increased pulmonary expression of ACE, the ACE receptor, where the COVID virus lands, and it provides a mechanism for patients with COPD to be more susceptible. In asthma, we see a decreased number of ACE2 receptors, so it may be that patients with asthma are not at risk like what we thought they were going to be. Patients with COPD are also at increased risk for hospital admissions and increased risk of developing severe death or severe disease and death. So this is just screaming that how vital pulmonary rehab is for our patients with these statistics and with this shown in the literature. So let's now talk about post-acute sequelae of SARS-CoV-2, or PASC. It's critical that we keep on learning. It's critical that we keep current. Reading the literature, I know articles have been published within, the speed of the publications are just overwhelming how great the world has done with publications. But it's our job to keep on learning and keep current in the literature. But it is now recognized that long COVID syndrome, or is clinically known as post-acute sequelae of COVID-19, PASC. And this is just an acronym that we use. And what defines PASC is it's patients who've been infected with the COVID virus for 28 days or longer. They're considered to have PASC. And other terms have been used in the past, like long haulers or post-COVID or long COVID. The definition is still being worked out, and we do not know yet the magnitude of this problem, but if we are at the forefront, ready to help with our pulmonary rehab, I think that's going to be critical. But given the number of individuals of all ages who've been or will be infected with COVID, the coronavirus, the public health impact could be profound. I don't think this is over yet. So again, this is just a name of all the different terms. But in the good news, and that is more good news, in December 2020, Congress provided a $1.15 billion in funding over 4 years for the NIH to support research for the prolonged health consequences. And they're going to be it already started, looking at what does the spectrum of the recovery from SARS-CoV-2 look like, and how many people continue to have symptoms of COVID, even develop new symptoms. Can you have reoccurring symptoms? Is it acute? Does it wax and wane? Does it get better? And we need to know this with pulmonary rehab patients, because as we were working with them 2 to 3 days a week for 6 weeks or 8 weeks, the program, it's going to be important that we're on top of it. We're a step ahead of the game, knowing what new symptoms have developed. And that's why I'm so glad you're here, and I'm so glad to get to talk to you about this. And I would love to come back if I can do this, learn more and present more, keep you posted. But they're also going to look at what makes some people vulnerable to SARS-CoV-2 and what is not. So that is going to be very good. So looking at the International Journal of Chronic Obstructive Pulmonary Disease published this just a few months ago, and it looked at pre-COVID. During COVID, there's pre-COVID hospital admission, clear evidence that could be health status. And then, but during COVID, there's temporary reimbursement policies. There's recourse and advice introduced for tele-rehab, which we'll talk about. And then post-COVID, they go home to the hospital. There's hybrid in-person or virtual exercise training, but not enough. And we look at the barriers. There's no evidence-based guidelines for tele-rehab at this point, at this publication. In inequality and access to internet. Some people can't afford internet. Some people don't know how to use the internet. There's just all these barriers. And then what we've seen for years and years and years is the need of tailored plans and transportation. There could even be transportation. So let's look at the physiopathology characterizations of COVID. The acute phase, the viral infection replicates, ongoing symptomatic COVID. Then we start to see, then after 4 weeks, and then on to 12 weeks, it could be 4 to 12 weeks. We see the pathophysiology is not known. We don't know what's going to be happen. Some patients have some symptoms, some patients have other symptoms. But I like this diagram looking at prolonged COVID ongoing, because we can see some ongoing systematic COVID symptoms and post-COVID syndrome. And this is just a time post. I just want to touch briefly on some of the symptoms we may see: fatigue, shortness of breath. They have brain fog, a neurological problem, sleep disorders, GI symptoms. I just want you to have this for reference. We need guidelines. We need guidelines desperately to achieve excellence in pulmonary rehab, and guidelines for evaluation of the post-COVID, post-acute COVID are being developed. This is an example. We won't go into detail here, but I just want to show you this is an example. But there are several large centers who've created post-COVID-19 clinics. You may know some, you may have some here. And they offer a multidisciplinary approach to evaluation and management, including follow-up for non-critically ill patients or post-ICU care. And it's really important that we stay on stay at the table, stay on the team, that we really be a big part in representing this. Just some more looking at, I wanted to touch just a little bit on the nervous system. We see that brain fog, and that's kind of hard with COPD patients, because we don't know if CO2 retention, if they're having problems with disease, or if this is post-acute sequelae of SARS-CoV-2. So they report brain fog as being confusing symptoms for the long haulers. They report forgetfulness, confused, unable to concentrate. Some patients say they can't even watch television or watch a movie, watch Netflix, because they can't concentrate. And it's intense, but we're not sure of how rare it is. And then another thing, the heart muscles, heart failure, we see damage to lung tissue, restrictive lung failure, and then also loss of lung function and shortness of breath. Overall, people think, I just don't feel like myself. That's what I'm seeing some post-COVID patients, and that's what I'm hearing them say. Lung injury, again, the respiratory system is the front line of SARS-CoV infection. This virus loves the lungs. The virus can injure our lungs and the lungs of COVID patients in 3 ways. It can look at acute respiratory distress syndrome. It can look at diffuse thrombolytic alveolar microvasculation, acute microvascular occlusion, and then inflammatory mediator response too. The studies show that 8.2% of total cases presented with rapid and progressive respiratory failure, and similar to ARDS. And this is exactly what I want us to understand, that we need to be here for these patients. Pulmonary rehab needs to start here, start early. Okay, And then again, that's what I just said. I just put it in a list. Long-term physical and psychological and cognitive impairment for both survivors, and it can affect the caregiver too. We can't forget them. So again, their treatment is very, very important. We have to remember the lungs are most vulnerable of all the organs to SARS-CoV-2. So will patients recover from COVID-19 have clinical sequelae? After the SARS outbreak, there were plenty of patients recovered. Many did. And I think sometimes, I mean, that was great. I was grateful for that. But sometimes I think a lot of people who recovered so quickly with minimal or no symptoms thought everyone was like that. So a lot of patient education and a lot of family education had to be done, and it still has to be done. The health consequences of COVID-19 extend far from acute infection, even those who experience mild illness. And it looks like of the sequelae, the clinical sequelae, fatigue tends to be most common in articles that I read, but they can have impaired physical functioning just after they're discharged to home, and even after they start early mobilization, when they start walking, or maybe when they start their pulmonary rehab program, they think they think COVID's gone, so they're going back to pulmonary rehab, or they're starting it, and then they present with these symptoms. In the absence of an effective treatment like pulmonary rehab, the consequences of this poor oxygenation are either death from the patient from respiratory failure, or the sequelae of permanent lung damage if the patient survives. Several studies will look at the Inspire one. I've been trying to follow this. This came in December 15, 2020, and there is Rush University is leading it, and it's Yale, University of Washington, Thomas Jefferson, University of California in Los Angeles and San Francisco, University of Texas, UT Southwestern, and I love that. I used to work there. And then I think Houston, University of Texas in Houston. But they're looking at a longitudinal study of outcomes of infection over the various groups in 2 years. So I'm just giving you this, and there's the link if you want to look at the studies, but I'm just giving you this to keep you can keep it current. 2 other studies a systematic study of sequelae after recovery from COVID is of course needed, and we need evidence-based multidisciplinary team approach to look at these. But Logue and his colleagues looked at persistent symptoms among adults, and they found that the cohort were followed for up to 6 months, but they had illness after up to 9 months, looking at longitudinal. And then there was 177 patients that had complications. Then another observational cohort over 38 hospitals in Michigan looked at outcomes of 1,250 patients discharged alive at day 60. And though there's about 488 patients completed a telephone survey, and they found to have patients still have persistent symptoms, new or worsening, about 32% or more had persistent symptoms, whereas almost 19% had new or worsening symptoms after discharge. And dyspnea, even walking up the stairs, was generally most common. And then lastly, a retrospective cohort looked at I love this study here. It's by Optum Labs, and it's published in the British Medical Journal. But they looked at 14% of individuals 65 and under 65 or who were infected with SARS-CoV-2 developed at least one new type of clinical sequelae that required medical attention. Increased risk of clinical sequelae. What they saw was cardiovascular problems, neurological, kidney, respiratory, and mental health complications. The risk of increased with age and pre-existing conditions, but the risk for some clinical sequelae were still elevated. So I thought that was a very good thing. Now, our patients, I know we're going through, um, we have to be prepared on questions. What might our patients ask us? Well, some common questions I get is who gets this post-COVID or this long haulers problem? And we know that, of course, it's the acronym post-acute sequelae, but people who've been infected with COVID-19 continue to exhibit symptoms for 28 days or longer. They're considered to have, that's what we would tell our patients, they're considered to have post-acute sequelae of SARS-CoV-2, but we're probably just going to call it long COVID, or we're not going to use a big fancy medical term unless they want us to. So, but there's new and upcoming data to look at who is determined to be more at risk. Another question patients are asking is, how long do people with long COVID experience symptoms from COVID-19 infections? Again, I guess long story short answer would be the literature is we're still studying this, but there's not a lot of information on it because, but it is receiving new attention from experts. The vast majority of post-COVID test negative for COVID-19, which is real interesting, and then they have symptoms. And there's nothing specific to the test lasting. We don't know that yet. But one common theory about patients with long-term COVID symptoms is that the virus possibly remains in their body in some type of small form. Another theory is that their immune system continues to overreact even though the infection has passed. The CDC showed that 35% of people with COVID-19 infection experiences symptoms for at least 2 to 3 weeks. So continuing to have symptoms past that time is looked at as, post-acute sequelae or post-COVID or long COVID. They may ask, is this going to damage my lungs? Well, the answer to that is not clear. Healthcare providers, we really don't, and healthcare professionals, we don't know what permanent damage is going to be done. We look at some patients that have been seriously ill from COVID, developed ARDS, and they have permanent lung damage or permanent scarring, but it's not clear if this scarring is from post-COVID who have respiratory issues, or is it the severity of the level of the ARDS. And then what are the symptoms? The loss of smell, still the same. Other patients with long-term loss of smell and taste worry about permanent damage to that. Experts, that's what I hear most is, am I going to be able to taste again? And experts believe that the loss of the smell and taste won't be permanent, but for many people, there will likely be, it will likely resolve, but there's no clear answers on this. So now let's look at the impact of lung function. First, reports on lung function related to COVID had a restricted effect. We see small airway dysfunction that can be persistent and not related to disease severity. There was a good article published here. Mo and colleagues reported that an impairment of diffusion capacity followed by restrictive ventilatory defects are both associated with the severity of the disease. So long story short with that is to know we need to closely monitor spirometry or pulmonary function testing. Literature, in order to obtain rapid restoration of normal lung function parameters, pulmonary rehab and gradual physical activity is shown to be effective in studies, but it's very, very important that we follow lung function along the way. There was a randomized trial on a 6-week pulmonary rehab after discharge, and it showed improvement in lung functions in FEV1, total lung capacity, the 6-minute walk test, quality of life, and it also, some studies showed a decreased anxiety in older patients. Lung damage during COVID correlates with reduction in pulmonary function. Again, it's so after 4 months. So it's very, very important that we follow pulmonary functions. And then the worst lung involvement during SARS infection showed impaired pulmonary function test parameters, and the 6-minute walk test with oxygen saturation 4 months after acute illness. Again, recent evidence suggesting, again, the organ most affected is the lungs. And again, we see complications here, alveolar complications, pulmonary consolidation, hyaline membrane formation. So real important, not only to follow pulmonary functions or spirometry, but also, looking at CT scanning if possible, or following signs and symptoms. PFTs in COVID-19 reduction, again, forced vital capacity. Post-infection patients showed impaired lung functions again in this study published in November of last year. Again, we look at the 6-minute walk test being reduced and impaired muscle strength. It's real important that we do inspiratory muscle training, I believe. Lung functions in COVID-19 pneumonia. We see a lot of COVID-19 pneumonia, fatigue and cough and frequent mucus production, all can, fever not, but all can, some of that can be, we think, is this COPD or is this post-COVID? So looking at that, but the majority of patients developing COVID-19 pneumonia has bilateral lung lesions. So COVID-19 pneumonia may result in significant alteration in lung functions. Again, very important to follow that. But if you see, again, we need to listen to their symptoms when they're in pulmonary rehab. Are you having any, tell me about your dyspnea, tell me about your nausea, are you having nausea, vomiting, diarrhea? The patients surviving to COVID-19 pneumonia generally present with restrictive pulmonary pattern, and it's shown to be associated with increased risk of life-threatening comorbidities. We also need to think about other lung functions that complement tests. Evaluation of respiratory performance under conditions with physiological stress, such as exercise, will provide detailed characterizations of functional impediment. Cardiopulmonary exercise testing is important, and then evaluation of respiratory muscle or airway resistance too is critical in our pulmonary rehab programs. So now, as we finish up, let's look at pulmonary rehab patients with PASC. So a burning question that we might be asking ourselves is, how can pulmonary rehab specifically help our patients who have a diagnosis of COVID-19 on top of COPD? Well, pulmonary rehab is crucial for both a patient who's admitted to the hospital and patient who's discharged. So it's very important that our inpatient pulmonary rehab be started, as soon as possible. Oops, I am so sorry. Went the wrong way. So I like to think with the end in mind. The global initiative, the GOLD guidelines, or Global Initiative of Obstructive Lung Disease, has incorporated pulmonary rehab standard treatment for patients with COPD as early as 2001. We need to remember that. We need to look at that. It's crucial for both admitted and hospitalized patients. And then benefits. We all know the benefits. Improves exercise tolerance, reduced number of hospital admissions, length of stay in hospital if they have to go back. And then enhanced skeletal muscle function of upper and lower extremities and relieve dyspnea. Multidisciplinary collaboration is essential. Clinical excellence in research must be coordinated to simultaneously to meet the needs of our patients. And we need to understand those long-term consequences of COVID. That's why attending lectures like this, it's important to know what is COVID and how do we, and understanding those long-term consequences. It takes I tell patients, it takes a village for disease management and pulmonary rehab too. So regular multidisciplinary team meetings provide avenues to discuss individual needs, disseminate and discuss evolving literature. What's new in the literature? I would love to serve as a resource, and I'm not, I could look anything up or provide you with if you need it, but continuing research or continue reviewing the literature. Most importantly, continue tracking outcomes to better understand the impact. We need outcomes to show, and then following our AACVPR and then your amazing MACVPR. So during the hospital admission, again, I know I've said this, but I really want you to take this home. Pulmonary rehab needs to begin at the start or at beginning at admission and go through admission and then go on into outpatient services into the community. No major pulmonary rehab interventions for critically ill patients until they become medically stable, of course, but there is signs of progressive, or if there's signs of progressive deterioration. But if there's not, it needs to be started. Early inpatient rehab includes respiratory care, bed, mobilization, bed to chair transfer, controlled breathing exercises as we do the bed to chair transfer, sitting and standing, going to, activities of daily living, and then even quadricep muscle function. I love this. We won't go into it, but the earliest publication of telerehab can be traced back to 1998. So this looks at telerehabilitation, and it may be challenging, or there may be some barriers which we'll talk about, but telerehab includes maintenance program, it includes exercise training, and one of my favorites is patient education. Improving our goal, as we all know, improve dyspnea, relieve anxiety, reduce complications, minimize disability, preserve function and quality of life, and improve our quality of life. And again, as we all know, it's tailored to meet each patient individually. We need to understand the basis of the patient's variances response to pulmonary rehab. We need to understand what individualized maintenance interventions work best. Does this intervention work best for this patient, but it doesn't even work for another patient? So we need to, of course, individualize our treatment and maintenance. Identify if exercise training and other interventions are not working, and then adjust it and do that along the way. Don't wait till week 4, week 5. Do that along the way, and monitor progression of lung disease, spirometry, pulmonary function. Look at fatigue and performance of activities of daily living. Is anxiety worsening? Did they possibly lose a family member? I know I've had patients with COVID who've lost their significant other, and now they have another layer of anxiety and depression, and because this devastating loss on top of the disease. Virtual pulmonary rehab, assess exercise capacity. I think COVID has, although it's been so awful, it's given us opportunity for new and upcoming things. But we need to monitor exercise response again, even if it's virtually, just like in person, and safety and educate in self-management interventions. Assessment and monitoring should be performed throughout the process again. Now, for hospitalized or for hospital admitted patients, there should be no early interventions, like I said. But I wanted to touch on those in isolation, that pulmonary rehab guidance could be conducted through educational videos or instructional manuals or remote consultation, again, being very, thinking outside the box. Maintenance pulmonary rehab and close monitoring and follow-up is key to success. We have to include the maintenance program, maintaining the benefits. We don't just start it and then they're discharged. We have to keep this up. This study, I love this study by Guel and colleagues, saw that, and he looked at a multi-center randomized controlled trial looking at 143 patients with moderate to severe COPD after a 3-year maintenance intervention of an 8-week pulmonary rehab program, and they had better maintenance of the 6-minute walk, airflow was better, and dyspnea scores and exercise capacity, again, has scored. That was over the course of 24 months compared to standard strategy, but there was no gains in initial pulmonary rehab after 3 years. But the reason is unclear. It could have been they didn't want to come back, or there was dropout because of other comorbidities or other personal problems. 6 keys to success: establish comprehensive long-term pulmonary rehab, follow up and maintain intervention, interact by occupational therapy, nutritionists, health psychologists, examine outcomes, Fatigue, does it get better? Performance of activities of daily living, does that better? Is anxiety decreased? Is depression better? Follow-up status on comorbid and physical activity levels, and engage in patient discussion. We have to sit face to face and you know, get to the heart of their problem, get to the heart of the disease. What's bothering them? Open-ended questions is the key here. Some barriers, unfortunately, with all good things, we have barriers. Disease severity, maybe their disease worsens so bad that they're unable to perform or to participate. Maybe medical comorbidities, physical inactivity. Maybe they've just lost motivation. Maybe there's no way. And gently just talking and letting them go at their pace, I have found that to be most successful. Just gently saying, we'll just do this when you're ready. Absence of family support, there could be from a loss of, the family member pass away, or their family move, their extended family move away, or maybe there's other problems. And then cultural and then geographical issues such as loss of transfer. I just wanted to tell you back to the telehealth or rehab, multiple randomized controlled trials accessing telehealth for COPD patients have demonstrated feasibility and non-inferior to care. We may think, oh, they're an older group that they may not understand how to use the internet, but everybody can learn. Real time, the benefits, there's real time asynchronous visits, remote evaluations. And this may be just like in clinical practice, telehealth can be done, telehealth is done currently I do telehealth just on a limited, maybe if I saw 10 patients, one may be telehealth. So most often we're face to face. That's the best. Well, the literature shows they can be equal, but looking at other opportunities, if coming to pulmonary rehab class doesn't, or program doesn't, there's a barrier. The telerehab is is a great option. There's also remote applications, like a phone-based application to conduct a 6-minute walking test with oximetry monitoring. There's all new things, and it's going to be so exciting to see what's up and coming. I just want to provide you just a reminder of the modified MRC dyspnea scale. This should be administered at each encounter or at least once a week. It really helps to keep current on how our patient is doing. The COPD assessment test should be administered along the way, however you do this, but I just wanted to touch on this to know that this is the refined ABCD assessment tool that Gold just published this year. Very, 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 very important. And then this is an older one, just how's your COPD? Take advantage of the survey. And here is the link for you. As the COVID-19 pandemic continues to affect millions of people all around the world, I know India, and I had a patient whose family is in Colombia, and they're on this is my patient telling me, so I don't know, if, how legit, but that they're not even starting, that a lot of people, it's so hard to get a vaccine, like we were in phase 1. But many of whom will require hospital admissions, respiratory symptoms. It's crucial to characterize the acute and chronic impacts that COVID-19 has on lung health. And pulmonary rehab plays such a vital role in patients' management and recovery from COVID-19. I like to look at COVID-19, although it's been such a devastating, unimaginable, every challenge, every obstacle, but our challenges today are tomorrow's opportunities. And I can see a lot of good things coming out, like patients, I think many patients are recognizing the need for preventative health interventions, and looking at what all we can do. And I think they're trusting us more. They're seeing what all, we're behind. We're in the trenches. Some of us are behind enemy lines. We're at the forefront. Some of us are a little further back, keeping people from going to the emergency room. So we all play such a very vital role. But I think our challenges today are opportunities for tomorrow. Here are some resources for you. Stay informed. And I want to thank you. Please know you can email me if you have any questions, or if and I can look an article up or whatever you need. And thank you with all my heart for inviting me to present at your conference. Thank you.
Wow, thanks, Dr. Gregory. That was very insightful. I know I learned a lot from that presentation. It also really fueled me again to remember what we're doing here and how we play a vital role in pulmonary rehab with these patients as well. So thank you for that, and very uplifting in that sense. So thank you. Mike, I'm going to kick it to you. I don't know if you have any Q&As that got sent to you, but do you mind handling that for me?
Casey, I didn't get any email to me, and there seems to be a problem with the Q&A function. So if you do have any questions, just go ahead and put it in the chat screen. I know, Casey, that you may have had a question come to you. Is that right?
Yeah, Karen, I think the real question, even for myself, is with dealing with these patients in pulmonary rehab. Some of them now are even a year out from their hospitalization, and they're still hanging on with needing 1 and 2 liters with activity. And just from your standpoint, what else would you tell these patients that are like, is this ever going to stop, needing this 1 liter with activity, or when is this going to stop? What is my outcome with this? I mean, what else would you tell these patients?
I think that's a great question. I think telling them the benefits and the why, it seems like if they understand why we're doing this, this is going to make you even have better outcomes. If we do it without, then it's not going to be, the outcome isn't going to be as great. And we want you to excel. We want you to exceed. And looking at the underlying, the why of it, the patient education of why they have to do this. We don't know. They may be needing supplemental O2 for all encounters, and it may get to where they even ambulating to the bed, to the bathroom, or getting, that may be requiring, if we see that this long COVID, or we see that the PACS, if it decrease, if it continues, we don't know. But I think just patient education is the key here, and showing that look. And then another thing, showing where they've been. Sometimes I think if we look back and see where we've been, that gives us the motivation and the energy to go forward.
Yeah, thank you for that. Yeah, sometimes it's just try to focus and show them what they are doing, as opposed to getting hung up on something like that, and just say, well, look what you're doing now compared to when you started this program, and what stronger you're getting. So
absolutely.
Well, thank you again, Dr. Gregory. I know this was very insightful and very helpful. And again, thank you for doing this kind of on short notice for us, but this is something that we really needed, and very helpful for us. So thank you again for being available to do this for us.
Oh, it's my great pleasure. And if I can do anything to help you, I would be honored.
Thank you. We appreciate that. Mike, thanks again for helping put this presentation on, as always. And the rest of the MACVPR board, thank you guys for being involved with this. This has been so helpful throughout the year for what we've been able to do without meeting in person. But thanks again for all your guys' work as well. We do have another webinar coming up July 22nd, and that one's going to be on wildfire smoke and its health impacts. So please stick around for that. Again, that's July 22nd. That one will be presented. And just so everybody knows too, I kind of talked about this last time, but we are going to be holding an MACVPR. We're going to be doing a board election coming this fall. We're going to do this via SurveyMonkey. We're looking for a president-elect and a secretary. Those are the positions up. So if you are interested or think you might be interested, please reach out to one of us. I posted the website link there in the chat feature as well. If you just go to officers, it has our contacts right there available on the website. So, if you guys just want to ask more questions about, commitments and things like that, please reach out to us. We'd love to hear from you and have you on. And then I guess the last thing too is we are looking forward to being back together as a group come April 2022. We're looking at spring conference already, but again, we're looking to get back in person for that one. So spring 2022, we got our mindset on Bozeman and making that happen. So we look to see you guys there at these future events coming up for us. And thank you again, everyone, for being involved with this.